My name is Youssef Dali, and I will try to explain you the role of transporters in drug disposition. As you know, there is a huge variability in drug disposition due to genetic and environmental factors. We have a variability in pharmacokinetics of drugs, absorption, metabolism, distribution, and elimination. And here we have two main factors: drug metabolism enzymes and transporters. In pharmacodynamic aspects, we have receptors and signaling pathways. Transporters are expressed in a variety of barriers, and their role is to regulate the movement of small molecules, drugs, toxics, or endogenous compound into or out of strategic organs. We have the brain, and then there is a blood-brain barrier, and we have liver, intestine, and kidney. More than 400 transporters have been annotated in human genome until now, and genetic polymorphisms have been associated with a part of these transporters, leading to some diseases or decrease of the activity of some drugs, as well as inefficacy of drugs. For instance, two inherited diseases called Dubin-Johnson and Rotor syndromes, which are characterized by the accumulation of bilirubin in blood, have been associated with altered activity of transporters. Bilirubin is uptake in hepatocyte by two main transporters, OATP1B1 and OATP1B3. In Rotor syndrome, this transporter, the reduced activity, and then we have an accumulation of bilirubin conjugate into the hepatocytes. In Dubin-Johnson syndrome, these transporters have reduced or nil activity, and then bilirubin cannot be extracted in the liver. Moreover, bilirubin is conjugated to bilirubin glucuronide that is transported to the bile by transporters called MRP2. Transporters are also involved in drug toxicity. As example, we have a differential effect of cisplatin versus oxaliplatin in the kidney. So cisplatin has a nephrotoxicity because it accumulates in epithelial cells in the kidney. So both cisplatin and oxaliplatin are substrate of OCT2, and they enter kidney epithelial cells by these transporters. And then cisplatin is a weak substrate of MATE1, while oxaliplatin is a strong substrate of MATE1. This transporter is an efflux transporter taking out the drugs from the epithelial cells to the urine. And cisplatin, since it's a weak transporter, it accumulates inside the cells, producing this nephrotoxicity, while oxaliplatin is a strong substrate of MATE transporter, and then it's eliminated from cells and there is no toxicity. Transporters can also be used as therapeutic target. For example, there is one drug called ezetimibe that inhibits one specific transporter in the gastrointestinal tract called NPC1L1. So this drug, by inhibiting this transporter, reduce the absorption of cholesterol. Then it can be used in combination with statins, for example, for lowering cholesterol in the blood and decreasing cardiovascular risk in patients. Finally, transporters are also involved in drug-drug interactions. For example, gadolinium bobta, a contrast agent used to enhance magnetic resonance imaging, is transported to the hepatocyte by OATP1B1 and OATP1B3, and then cleared from the hepatocytes to the bile by a transporter MRI-P2. When it's administered concomitantly with rifampicin, that is a strong inhibitor of OATP transporters and MRP2 transporters, there is a decrease in the entrance of this contrast agent to the hepatocytes, decreasing then the quality of contrast imaging.